Okay, we're going to palpate the foot and ankle and some of the lower leg today. So we'll start up here on the lower leg and work our way distally. So we're going to start with the tibia. We've already talked about the tibial plateau when we talked about the knee and the tibial tuberosity. And we're going to work our way down the tibial crest here. That's that sharp edge of bone of the tibia that runs all the way from superior to inferior. And this entire medial region of the tibia is exposed there. So you should be able to palpate bone and get a bony end feel all the way down. So if we follow the tibial crest and this medial shaft of the tibia all the way down, we'll run into the medial malleolus down here. On the lateral side, we have the head of the fibula, which we've talked about with the knee. So we can palpate that with the palm of the hand and then get more detailed with our palpation with our finger pads. Remember the fibular nerve runs right under the fibular head and on the fibular neck right there. So we can also follow the shaft of the fibula all the way down. This bone, unlike the medial crest and the medial tibia, this is covered with muscle. So we have the fibularis longus and brevis muscles coming all the way down here. So when you palpate the shaft of the fibula, you can palpate it from anterior, posterior, and lateral, and you can kind of get an idea of the shape and the size of the bone all the way down. And then distally, as we move down, the bone becomes exposed, and you can palpate the lateral malleolus because the bone's exposed and you get that bony end feel down there. Some of the muscles on the leg that are more prominent, we have the tibialis anterior, laterally right here. So if the patient dorsiflexes and inverts the foot, that'll activate this tibialis anterior, and you should be able to feel the muscle belly all the way up under the tibial plateau here, and you can follow it all the way down, and the tendon becomes extremely palpable here across the front of the tibia and the ankle, and you should be able to feel that tendon. It should be very easy to feel if the muscle's contracted. Just lateral to the tibialis anterior, we have the extensor digitorum longus muscle. That also aids in dorsiflexion, but it also does toe extension. So one way to differentiate the tibialis anterior from the extensor digitorum longus is to have the patient plantar flex. That takes out the tibialis anterior, but have them still extend their toes while they're in plantar flexion, and that should activate the extensor digitorum longus, as that muscle runs down the anterior shaft of the fibula and the interosseous membrane here and comes across the foot, and the tendons insert into these lateral four toes and help with toe extension. Okay, we've also got the fibularis longus and brevis. The fibularis longus comes off of the upper shaft of the fibula, and the fibularis brevis on the lower shaft of the fibula. The fibularis longus sits over the top of the fibularis brevis, but they both run down together. They're easily palpable if the patient plantar flexes and everts the foot in this direction. You should be able to feel those muscles contract along the shaft of the fibula. And then you can also feel the tendons as they run behind the lateral malleolus right here. The fibularis brevis being more anterior and going to the base of the fifth metatarsal, and the fibularis longus wrapping underneath around the cuboid here and going to the base of the first metatarsal and the medial cuneiform bone. Okay, lastly, anteriorly, one other thing you should be able to see is the greater saphenous vein. This runs down near the shaft of the medial shaft of the tibia and comes down across the in front of the medial malleolus right here. It's pretty easily palpable, especially if the patient is sitting in a dependent position, and you should be able to visualize that as well. Now with the patient in a hook-lying position here, we can start to palpate the structures of the ankle and the foot anteriorly. So the patient can either be in a hook-lying position like this. You can also palpate this in supine or in a seated position. So first we're going to palpate the talus, and I think the easiest way to palpate the talus is to put your finger on the tibia, run down the crest or the shaft of the tibia until you roll across this talocrural joint right here. And the first thing you land on that sits horizontal should be the neck of the talus and the dome of the talus. So you should be able to land right on top of the dome of the talus right there, and that should be the first thing running horizontal after you fall off the tibia. So once we land on the talus right here, we can move just laterally, and we're going to be above the lateral malleolus right here. but you should be able to palpate the distal end of the tibia right here and feel where that tibia and that fibula come together to make the distal tibiofibular joint. We've already mentioned this, but we can also find this talocrural joint by finding the medial and the lateral malleoli. So one easy way to palpate these is to come in with the palms of the hands. You should be able to locate them fairly easily. And you'll notice that the lateral malleolus of the fibula sits a lot lower than the medial malleolus. So our joint vector runs in this direction, or the axis of our joint is sort of diagonal in this direction. Okay, also anteriorly, we can find these tarsal bones and all of the metatarsal heads and bodies down here, as well as the phalanges down here. And we'll get into more detail in those in just a second. So a few of the muscles of the lower leg and the foot that we're going to cover anteriorly is, we've already been over the tibialis anterior and the extensor digitorum longus. You can palpate both of those tendons again as they cross the ankle here, and the extensor digitorum longus as it crosses the ankle and traverses across the dorsum of the foot, going to the four lateral toes. We also have the extensor hallucis longus muscle that the muscle belly sits underneath the tibialis anterior and the extensor digitorum longus, and its tendon comes out and crosses the ankle and goes down the shaft of the first metatarsal all the way to the distal phalange of the first digit here, and that aids in toe extension. So easy way to palpate the extensor hallucis longus muscle is to have the patient extend their great toe, and you should be able to see and feel that tendon as it comes proximally and disappears at the lower leg. Another muscle on the dorsum of the foot is the extensor digitorum brevis muscle. Its muscle belly sits right here near the sinus tarsi. The sinus tarsi being this little cavity made by these bones. So it sits right near the sinus tarsi, and if its action is to extend the lateral four toes. So if the patient does toe extension, you should be able to see and feel this little tiny muscle belly contract right here, and it looks like a little bubble that pops up in the foot. So that's palpable there, as well as its tendons as it crosses the dorsum of the foot. Okay, and lastly we have the dorsal pedal artery, and that runs across the dorsum of the foot. If you have the patient contract the extensor hallucis longus, or the EHL, and you move just lateral to that tendon right here between the first and second metatarsals, you should be able to palpate the pulse of that dorsal pedal artery. All right, on the lateral side of the leg and foot, we've already talked about the fibula and the lateral malleolus here. So we can palpate the lateral malleolus, and this will help us to find a bunch of other structures around here. If we come just anterior to the lateral malleolus, we'll find this little indentation in the bones formed by the talus and the calcaneus and the navicular and the cuboid bone. And there's a little indentation here called the sinus tarsi. And if we palpate into the sinus tarsi, it becomes more palpable. If you have the patient invert and plantar flex their foot, it becomes more palpable. And you can palpate in there. And once you're in there, you're going to be right on the neck of the talus. And this also serves as an insertion site for the anterior talofibular ligament. And the extensor digitorum brevis muscle sits right here close as well. Okay, next we have the lateral collateral ligaments of the ankle. So there's three of them. There's one coming from the fibula to the talus called the anterior talofibular ligament, meaning going from the talus to the fibula, right there. And that resists plantar flexion and inversion. Next we have the calcaneofibular ligament. So going from the calcaneus to the distal fibula, that resists ankle inversion. Okay, and lastly, we have the posterior talofibular ligament going from the posterior tubercle of the talus to horizontally over here to the fibula, and that resists dorsiflexion and inversion, just opposite of the anterior talofibular ligament. We can also find the lesser saphenous vein running between the Achilles tendon right here and the lateral malleolus right here. If the patient is in a sitting or dependent position with the legs hanging down, and gravity pulling that blood down, you'll usually see it and palpate it right there between the Achilles tendon and the lateral malleolus. Next, we can palpate the calcaneus. That's very easy to palpate. So I would come in from the back side. You can feel where the Achilles tendon comes in and just get an idea of the shape and the size of the calcaneus posteriorly. And you can follow it anteriorly as you come in, there the body should get a little bit smaller than that posterior side. Okay. Laterally, we have the most prominent portion of the foot, and that's the styloid process of the fifth metatarsal. So we can palpate that by coming in with the palm of the hand and feeling that projection of the fifth metatarsal right here, that styloid process. If you find the styloid process, you can easily find the cuboid bone. So if I just come posterior and drop off that styloid process, my finger is going to drop right onto the cuboid bone right there. And then I can, once I've got the cuboid bone located, then I can actually palpate it from the anterior or dorsal side and the plantar side as well. Okay, lastly, a muscle along the lateral side of the foot. If you have the patient abduct their pinky toe, so their fifth digit, if they abduct it, that will activate the abductor digiti minimi muscle running across the lateral side of the foot here, and you should be able to feel that little muscle contract as it pulls the fifth digit away from the foot. Okay, now we're going to move to the medial side of the ankle. So we've already located the medial malleolus. Use the palm of the hand, come into the medial malleolus and use your finger pads to get a more detailed palpation of the medial malleolus. Once we've found this structure, we can find a lot of other structures around it. So once we've found the medial malleolus, we can start off by finding the medial tubercle of the talus. If you come just off the end of the medial malleolus and the first bone you land on posteriorly is the talus, and this little portion right here is the medial tubercle of the talus. So just distally to the medial malleolus and the medial tubercle of the talus, just underneath those we have the sustentaculum tali, and that can be confusing because it sounds like it's on the talar bone, but it's actually a portion of the calcaneus. So it's a little projection or a little shelf that comes medially and makes a little shelf for the talus to sit on. The easiest way to find this, I think, is to come from the soft tissue side of the foot and work your way up medially, feeling all this this soft tissue right here. And the first bony end feel that you run into as you come up the medial side of the foot toward the medial malleolus is going to be that sustentaculum tali. If we move distal and anterior to the medial malleolus, there will be a little bony projection right here that you'll run into on the medial side of the foot called the navicular tuberosity, and that's part of the larger navicular bone. Now between this sustentaculum tali and this navicular tuberosity, there's a ligament called the calcaneo-navicular ligament, or also referred to as the spring ligament. You can come up between those two if you palpate the sustentaculum tali and the navicular tuberosity. You can come up in the soft tissue space between those and palpate that ligament, and it becomes more taut as the patient or the subject stands up and puts weight through the foot. That ligament will become more taut, so it helps to hold the arch of the foot there. Another set of ligaments that we have on the medial side of the foot is called the deltoid ligament, and it's actually a set of 4 ligaments that come off the medial malleolus. First, we have the anterior tibio-talar ligament. So that comes off the medial malleolus and goes to the talus right here. We also have the tibio-navicular ligament. So that comes from the tibia and comes to this navicular tuberosity down here. We have the tibiocalcaneal ligament that comes off the tibia and goes to the calcaneus, this sustentaculum tali right here. And then we have the posterior tibio-talar ligament running from the medial malleolus to the medial calcaneal tubercle or tuberosity. Okay, also on the medial side of the foot we have a structure called the tarsal tunnel. So this comes from the flexor retinaculum, which is a ligament that holds in all of these muscles and all of this neurovasculature running down the leg into the foot. So if we palpate behind the medial malleolus right here, we'll be able to find 3 muscles. The first muscle being the tibialis posterior, the next muscle being the flexor digitorum longus, and the last muscle being the flexor hallucis longus. So those are, in anatomy, you might learn those as Tom, Dick, and Harry. So tibialis posterior, flexor digitorum longus, flexor hallucis longus. And then we also have the neurovasculature, which includes the tibial artery running around there. We have the tibial vein, and we also have the tibial nerve. So if I wanted to palpate any of those, you can palpate behind the medial malleolus and feel the tibial pulse right there. If I wanted to palpate the nerve, you can move back and forth, and the patient might feel a little bit of a zinger into the foot, but you can palpate the tibial nerve running behind there. And then we can also palpate those muscles. So if I wanted to palpate the tibialis posterior, I would have the patient plantar flex and invert the foot, and that'll activate that tibialis posterior muscle running around the backside of the malleolus. If I wanted to activate the flexor digitorum longus, then I'd have them flex the toes forward, and that would activate that flexor digitorum longus. And the flexor hallucis longus, if we flex the great toe, that'll activate the flexor hallucis longus. So that's how you can differentiate between all those muscles back there. And you can try to follow their muscle bellies up. They become a lot less palpable on the backside of the tibia, but you can palpate a couple of those muscles, the muscle bellies on the backside of the tibia, and the tendons become more palpable behind the medial malleolus. Okay, we've also got the tarsal bones down here in the midfoot region. So if we come back to this navicular tuberosity, this is a very nice landmark for us to find all of these other tarsal bones. So come just distal and anterior to the medial malleolus, and you'll find that navicular tuberosity. So one easy way I like to do this is if I put a finger on that navicular tuberosity and I drop another finger down, that finger should land right on that medial cuneiform bone. And the same thing goes with finding the base of this first metatarsal. So I can find the navicular tuberosity by dropping a finger there. My next finger down should drop right onto that medial cuneiform, and the next finger down should drop right on the base of that first metatarsal. Once you've kind of located the bodies of those bones, then you can find the joint lines between the navicular bone and the medial cuneiform, and the medial cuneiform and the base of the first metatarsal. If I find that medial cuneiform bone and move about a finger's breadth laterally, I should drop onto the intermediate cuneiform, or that second cuneiform. And I can do the same thing if I find that intermediate cuneiform and drop a finger right down, another finger's breadth laterally, then I should drop right onto that lateral cuneiform bone. Another easy way to find those bones is to follow the shafts of the metatarsal bones up, and you'll notice that the first metatarsal articulates with this medial cuneiform bone. So this is a very easy bone to palpate. I can palpate the shaft of that bone and work my way up. I can feel that little bump where that joint line is, and then I can drop right onto the medial cuneiform. I can follow the second metatarsal up and do the same thing and drop onto the intermediate, and then I can follow that third metatarsal up, cross the joint line, and drop onto the lateral cuneiform. Okay, lastly, some of the muscles of the posterior leg that we palpated already in palpation. We've got the gastroc muscles. If you have the patient extend the knee and plantar flex the ankle, you should be able to see the medial and the lateral heads of those gastrocs, and those cross the knee and attach to the back of the femur. Just underneath those gastroc heads, we have the soleus, and the soleus is palpable underneath the gastroc heads, and you can follow that down. And both of those muscles converge to form the Achilles tendon, which inserts onto the posterior calcaneus. There's a couple of bursae that are associated right here, the retrocalcanea bursa, and that can become tender in some patients who develop Achilles tendon issues. If we look on the plantar surface of the foot, we have the medial calcaneal tubercle right here. This is this outcrop of bone right here that serves as the insertion point for the plantar fascia. So the plantar fascia is a large, broad, thick ligament that runs across the bottom of the foot from the medial calcaneal tubercle to these metatarsal heads and the bases of the proximal phalanges. So one way to easily palpate this medial edge of the plantar fascia is to have the patient extend the toes, and you should be able to feel that medial edge of the plantar fascia run all the way from that medial calcaneal tubercle all the way down to the toes. Okay, we've also got the abductor hallucis muscle, and this is a muscle that runs from the calcaneus all the way down to this proximal phalange of the first digit. and its job is to abduct the great toe. So it pulls the great toe medially. That's very hard for most people to do, to abduct the great toe. So one thing you can do is just try to flex the toe at the metatarsal phalangeal joint, and that should activate that muscle, and you can feel that muscle run across the medial side of the foot. And then lastly, we have the metatarsal heads. If I extend the toes, that should expose these metatarsal heads. And on this first metatarsal, there's a couple of sesamoid bones that you should be able to palpate and actually move around. So a sesamoid bone is a bone that's movable and that usually sits inside of a tendon, much like the patella at the knee. So you can actually get a hold of these bones and move them around, but there's two sesamoid bones right there at the first metatarsal. Okay, we're going to work down some of the structures of the leg here, starting with the tibia. So here's our tibial tuberosity. We can follow the tibial crest all the way down. That's that sharp edge of bone. We can palpate that all the way down, and we can follow it all the way until it becomes the medial malleolus. So this medial side of the shaft of the tibia should be very exposed, and you should be able to get that hard end feel all the way down and feel as it becomes the medial malleolus. Okay, we can palpate the medial malleolus by using the palm of the hand and then coming off with the finger pads and following the borders of that medial malleolus. It extends distally here, but across the front of the ankle it comes up and forms the anterior portion of that ankle mortise. So we can follow that distal tibia all the way across the ankle joint and to where it meets up with the fibula. So where the tibia and the fibula meet up, tibia and fibula meet up distally is the distal tibiofibular joint. And then we can also palpate the fibula in a similar fashion. So if we find the fibular head up here close to the knee, we can locate the fibular head. The fibula is covered by muscle almost all the way down until this last quarter. So when you're palpating the fibula, you're palpating through that fibularis longus and brevis muscle. And so you've got to expect there's going to be a different end feel when you palpate, but you can palpate through those muscles and get that hard end feel. And you can actually follow that fibula all the way down and get an idea of the shape and size, anterior to posterior. And as you come more distally, that fibula becomes exposed right here at the distal end. And now I get that bony end feel, and I can follow that all the way to the lateral malleolus. So get an idea of the borders of the lateral malleolus. And this medial and lateral malleolus should help you define a bunch of other structures. So notice the orientation of the talocrural joint right here. I have the medial malleolus here and the lateral malleolus here, and I've got this diagonal plane here that we're dealing with. So when we get dorsiflexion and plantar flexion, it's not perfectly in that plane. It's got a little bit of diagonal movement to it. Okay, we're going to cover a few of the muscles of the leg that are more prominent. The first one being the tibialis anterior, coming off the lateral portion of the anterior tibia and going across the ankle. The tendon crosses the ankle here and goes to the base of this first metatarsal. So I'm going to have the patient dorsiflex and invert the foot right there, and we can see that tibialis anterior muscle contract and follow that muscle belly all the way down. You can see the tendon cross the ankle right here. It's a very large, broad tendon, and go all the way to the base of that first metatarsal here. Just lateral to the tibialis anterior, we have the extensor digitorum longus muscle. So this muscle also aids in dorsiflexion, but I don't want to activate the tibialis anterior, so I'm actually going to have the patient plantar flex the ankle and then extend the toes, because this is a toe extensor, and you should be able to feel and see that extensor digitorum longus muscle. It comes off of the proximal anterior fibula and the interosseous membrane and runs all the way down, and then you should be able to see the tendons as they cross the ankle right here in a group, and then they fan out across the foot, and you can see each of those individual tendons sending slips to each of those lateral four toes. Okay, on the lateral side of the leg, we have the fibularis longus and brevis muscles. So starting here at the fibular head, just under the fibular head, we have the fibularis longus, And underneath the fibularis longus, about halfway down, we have the fibularis brevis. Those go all the way down the fibula, and their tendons wrap around the backside of the fibula, around this lateral malleolus, with the fibularis brevis going to the base of the fifth metatarsal, and the fibularis longus wrapping all the way under, across the top of the cuboid bone, all the way under to the medial cuneiform and the first metatarsal, the base of the first metatarsal here. So to palpate those and to make them contract, I'm going to have the patient plantar flex and evert the foot. So plantar flexion and eversion. And we should be able to see the muscle bellies there tighten up on the shaft of the fibula, and you can follow those all the way down, and you can see and palpate those tendons as they wrap around the lateral malleolus. And here's the tendon of the fibularis brevis going to the base of the fifth, and the fibularis longus wrapping under the foot all the way to the base of the first. Going back to the front of the ankle here, we've talked about the ankle mortise that's formed where we have the medial malleolus medially, and it comes up just a little bit, and then laterally we have the lateral malleolus coming down. So those form a mortise, and the talus sits up in top of that, in the top of that mortise. So if I follow the tibial crest down, the first thing I run into that's running in a horizontal position is the dome of the talus right there. So as the patient plantar flexes, it exposes the dome of the talus, and as he dorsiflexes, the dome of the talus disappears. But I can feel that dome and that neck of the talus right there, and I know that the ankle, that talocrural joint is right there. One other way to palpate the neck of the talus is to get on each side of these tendons here. So I've got the tendons of the extensor digitorum longus and this tibialis anterior. If I come on either side of those tendons and just come anterior to the medial malleolus and the lateral malleolus, I'll be right on the neck of the talus right there. Okay, we've already covered the extensor digitorum longus. But if we have the patient extend the lateral four toes, we can see those tendons running across the dorsum of the foot. We can also palpate the extensor digitorum brevis in the same way. With toe extension, we get the muscle belly of the extensor digitorum brevis contracting right there, and it sends slips to these lateral toes as well to extend these toes. And then we get the extensor hallucis longus muscle. So here's the tendon of the extensor hallucis going to the great toe. You can see it and palpate it across the dorsum of the foot. And it crosses the ankle here, and we can palpate it all the way across the ankle. Once we cross the ankle, it gets a lot harder to palpate because that muscle belly disappears between the tibialis anterior and that extensor digitorum longus. So the tendon is very easy to palpate, but the muscle belly is a little more difficult. If I have him contract this tendon, I can also find the dorsal pedal artery. So if I find the tendon right here and just go laterally on the dorsum of the foot, now go ahead and relax, then I should be able to find that artery and that pulse. Right there, I get a little bit of a pulse from him. So that's a nice way using the extensor hallucis longus tendon to find that dorsal pedal artery. Okay, if I put the patient in a dependent position, I can also find the greater saphenous vein. So it's good to be aware of this vein while you're doing other physical therapy palpation and treatment, but especially in a dependent position, that vein will usually become prominent across the anterior surface of the medial malleolus right here. So I can palpate and see the vein, that greater saphenous vein right here in front of the medial malleolus. Okay, so laterally, we can find the lateral malleolus in the same way we found the medial malleolus. So use the palm of the hand, get an idea of where it's at, and then follow with the pads of your fingers to locate the borders. This structure, just like the medial malleolus, is helpful to help us find a lot of other structures. So once we found the medial malleolus, the first structure we're going to locate is the sinus tarsi. So the sinus tarsi is a little cavity in the foot caused by the convergence or formed by the convergence of the talus and the calcaneus and the tarsal bones anteriorly. So it's kind of a little hole in the foot right there. If I have the patient plantar flex and invert the foot, that makes that structure more prominent, and you can palpate in there. If I palpate medially, I'll run into the neck of the talus. If I palpate inferiorly, I'll run into the top side of the calcaneus. And if I go posteriorly, I'll run into the body of the talus. So that's the sinus tarsi. And we also have the anterior talofibular ligament that attaches there, and that extensor digitorum brevis muscle that sits close to there as well. So let's cover the lateral collateral ligaments of the ankle right now. So there's 3 lateral collateral ligaments of the ankle. The first one we have is the ATFL, or the anterior talofibular ligament. It goes from the talus, the neck of the talus, right here in the sinus tarsi, to the fibula, the distal fibula on the lateral malleolus. And it resists plantar flexion and inversion. So the best way to palpate that is to put the patient into passive plantar flexion and inversion, and you may be able to feel that ligament as it crosses from the lateral malleolus to the talus. The next one is the calcaneofibular ligament, and this resists straight inversion. So if I put a finger on the distal side of that lateral malleolus and palpate in a transverse fashion here, I may be able to feel that ligament get taut under my fingers as I put the patient into inversion. And lastly, we have the posterior talofibular ligament running from the talus to the distal fibula, and that resists dorsiflexion and inversion. This one's a lot harder to palpate, but that's if we were to palpate it, that would be the stressor for it, or to make it tight would be to dorsiflex and invert. Right. We can also locate the lesser saphenous vein laterally. So you can see it crossing between the lateral malleolus and the Achilles tendon here. This would be better if the patient was in a dependent position. We'd be able to see it a little easier. And then we've also got the calcaneus back here. So the calcaneus is extremely easy to palpate and visualize. So one thing you might want to do is just palpate the backside of the calcaneus, and then just move anteriorly, both on the medial and on the lateral side. Move anteriorly and just get an idea of the size and the shape of the calcaneus. You can come superiorly and come on the top of the calcaneus here in front of the Achilles tendon. And so a very easy bone to palpate. So just try to get an idea of the size and the shape of that calcaneus. If I come from the plantar surface, we have this fat pad, so it's a lot harder to get that bony end feel that we're looking for. But if we palpate through that fat pad, we get that nice hard end feel. Okay, also located on the calcaneus is the fibular or peroneal trochlea. So if we go just distal to the lateral malleolus, there's a little outcrop of bone right here on the calcaneus, and that serves to split the tendons of the fibularis longus and brevis muscles and to redirect those tendons. So on the superior side of this fibular trochlea, we have a little groove for the fibularis brevis tendon, and on the bottom side we have a little groove for the fibularis longus tendon, and that trochlea is right there. Okay, we've also got the base of the 5th metatarsal and styloid process. So the most lateral portion of the foot is the 5th metatarsal base and the styloid process. So I can palpate right there and really visualize that right there. And once I've located that 5th metatarsal styloid process, I can actually just move posteriorly and drop off that into that soft tissue space, and I'll drop right on top of the cuboid bone. Once I've got a finger on that cuboid bone, then I can locate it superiorly on the dorsum of the foot and inferiorly on the plantar surface of the foot, and you can really get a hold of that cuboid and even move it around a little bit. Okay, and then lastly we have the abductor digiti minimi muscle, which is a muscle that sits on the lateral surface of the foot and serves to abduct the fifth phalange. So go ahead and try to spread your toes there. A lot of people have difficulty doing this, but when they abduct that toe, you can feel that muscle right there contract, and it's got 2 bellies, one from the calcaneus to the base of the 5th and one from the base of the 5th to the actual phalange itself. So that's the abductor digiti minimi. Okay, we're going to move to the medial structures of the foot, starting with the medial malleolus. We can palpate the medial malleolus and locate the borders with our finger pads. Once I've located the medial malleolus, I can come just posteriorly here, and especially if I give a little bit of eversion and some dorsiflexion, I can palpate that medial tubercle of the talus back here. So here is the medial malleolus, and just posterior to that, the medial tubercle of the talus, and that serves as an attachment site for our deltoid ligament, which we'll mention in just a second. So just under the medial malleolus here, we have a bony structure called the sustentaculum tali. It's an outcrop of the calcaneus. It's a little shelf that comes out of medially on the calcaneus, and it allows the talus to sit right down here on top of it, and it also serves as an attachment site for a couple of ligaments. Anterior to the medial malleolus and to the sustentaculum tali, we have another bony outcrop called the navicular tuberosity right here. So the navicular tuberosity is a portion of the navicular bone, a tubercle on the navicular bone. So once I locate that navicular tuberosity, I can come up toward the dorsum of the foot laterally, and I know I'll be right on top of that navicular bone. And then between that navicular tuberosity right here and that sustentaculum tali right here, we have the plantar calcaneo-navicular ligament, or the spring ligament, that serves to uphold the arch of the foot. And we've also got the deltoid ligaments. So collectively it's called the deltoid ligament, but we can separate these into 4 different portions of this ligament. The first being the anterior tibio-talar ligament, coming from the neck of the talus to the medial malleolus. We also have the tibio-navicular ligament coming off of the tibia here, the medial malleolus, and running down here to the navicular tuberosity. We've got the tibio-calcaneal ligament coming off of the medial malleolus here and going to the sustentaculum tali on the calcaneus. And then posteriorly, we have the posterior tibio-talar ligament going from the tibia to the talus posteriorly on that medial tubercle of the talus. On this medial side, we also have the tarsal tunnel and its contents. So there's 3 muscles that sit inside the tarsal tunnel. The tarsal tunnel is a tunnel that's created by the flexor retinaculum of the ankle coming off of the medial malleolus here and creating a tunnel for structures to run through. The first of the muscles that runs through here is the tibialis posterior, coming off the back side of the tibia, and its tendon running posterior to the medial malleolus and going under the foot. It creates plantar flexion and inversion. And so if we have the patient plantar flex and invert, we can actually see and feel the tendon of the tibialis posterior running behind that medial malleolus. We also have the flexor digitorum longus. So if the patient scrunches those lateral 4 toes, we can feel that tendon running again behind the medial malleolus. And lastly, we have the flexor hallucis longus. So if the patient flexes the great toe, we can also palpate that tendon running behind the medial malleolus there, and those muscle bellies going more proximally behind the tibia. The other contents of the tarsal tunnel include the tibial artery, nerve, and vein. The tibial artery, if you palpate behind the medial malleolus, this one's more faint, but you should be able to get a pulse. I get a pulse right there behind the medial malleolus. And we can also find the tibial nerve. If you palpate in a transverse fashion, that nerve is coming this way and splitting into other branches as after it crosses behind the medial malleolus. So if we palpate just distal to the medial malleolus and posterior to it in a transverse fashion, we can get that nerve right there to roll under our finger. Okay, lastly, we have the medial side of the calcaneus, which we've palpated previously. And then we've got the cuneiform bones, which we haven't been over yet. So to find the cuneiform bones, they're part of the tarsal bones that traverse the midfoot right here. So if we find that navicular tuberosity right here, and if we go 1 bone distally, we'll be right on that medial cuneiform. So one way I like to do this is to palpate the navicular tuberosity and then lay a finger right down next to that navicular tuberosity, and I should be right over the top of that medial cuneiform bone. Also, if I palpate that navicular tuberosity, I can find the base of the first metatarsal in the same way. So here's my navicular tuberosity right there. If I lay my first finger down, I'll be right over that medial cuneiform. And if I lay one more finger down, I'll be right over the base of that first metatarsal. Then you can palpate the joint structures in between each of those bones. So I have base of the first with its joint space. I have the medial cuneiform with its joint space, and that's articulating with that navicular bone more proximally. So similarly, if I can find that medial cuneiform, so here's my navicular tuberosity, and here is my first cuneiform, or my medial cuneiform. If I lay a finger down next to that medial cuneiform, I'll be on that intermediate cuneiform. And if I lay one more finger down laterally, I should be on that lateral cuneiform there. Another way to find those cuneiform bones is to follow the metatarsals up. So the first metatarsal, if I follow that up, cross the base of that first metatarsal, and you should be able to feel that base flares up just a little bit, and then you should be able to feel a joint space right there, and then the next bone is going to be my medial cuneiform. So that first metatarsal goes to the first cuneiform. My second metatarsal, if I follow that up, goes to the second cuneiform, and my third, if I follow that up, goes to that third cuneiform bone. All right, with the patient in a prone position, we can palpate some of the muscles of the posterior leg. So if I have the patient plantar flex against some resistance, I can palpate those gastroc heads. So here's that lateral gastroc head, and here's this medial gastroc head. Underneath that, I can see and palpate the soleus. So that soleus runs all the way up underneath those gastroc heads. A lot of times you can find it laterally, and then definitely distally, we can find that soleus. The gastroc and the soleus complex converge distally to form the Achilles tendon, which inserts broadly at the calcaneus. If I passively put the patient into dorsiflexion, I can stretch that Achilles tendon and get a really good idea of the size and shape of that Achilles tendon. And I can even palpate the top of the calcaneus in front of that Achilles tendon there as well. Lastly, on the bottom side of the foot, we're going to locate the medial calcaneal tubercle. So if we find that portion of the foot where the arch of the foot and the calcaneus meet up on that medial side, we'll be right on that medial calcaneal tubercle. It's an outcrop of bone on the calcaneus that serves as an origin site for the plantar fascia. So if I extend the patient's toes, I should be able to see and feel that plantar fascia running from that medial calcaneal tubercle all the way across the metatarsal heads there. And this medial border is very easy to palpate. So with toe extension, I can follow that medial border all the way down as it crosses that metatarsal head. And laterally, it's a little more difficult to palpate, but you should be able to follow it across the arch of the foot all the way down. We can also palpate the metatarsal heads here by extending the toes. That exposes the tips of the metatarsal heads, and we can palpate each metatarsal head starting from 1 and going all the way through 5. And we can palpate the sesamoid bones of the first metatarsal head here. If we get the patient into passive flexion, we can palpate around for those sesamoid bones, and those should be movable, moving with the tendon of the flexor hallucis brevis muscle. So sesamoid bones in there. If we extend the toe, those sesamoid bones lock up against the first metatarsal head and get very tight, so they become more difficult to palpate. Lastly, we have the abductor hallucis muscle running from the medial calcaneus all the way to the proximal phalanx of the great toe. Most people can't abduct their toe, so what we'll have them do is just flex the toe at the proximal phalanx. So go ahead and give me some flexion here. So if we have them flex the toe at the proximal phalanx, that should allow that muscle to contract, and you should be able to feel that muscle belly contract all the way along the medial side of the foot.